Assistant Professor Pediatric. Today we are going to discuss an important topic, that is diabetes mellitus in children. So diabetes is one of the commonest issue of the world, but particularly of the developing world. Dear student, you know about World Diabetes Day. I hope that you all know about that, but I tell you, the World Diabetes Day is 14th November. Okay, so 14th every years. This is a World Diabetes Day, and the aim of this is to create awareness in the public and for the diabetes, how we will control, what precautions, how we will prevent the complications, how we will screen. So 14th November is World Diabetes Day. Regarding the global burden, the global diabetic prevalence in 2019 is estimated 9.3%. It is approximately 463 million people, rising to 10.2 or 578 million by 2030, and 10.9 is 700 millions by 2045. Pakistan ranked 4th in the 2019 and may rank to 3rd by 2045. So the incidence of diabetes is higher in Pakistan, and it is one of the worried condition. And the most common diabetic problems are: number one country is China, India, US, Pakistan, and Brazil on the number 5th. So it is one of the alarming situation for Pakistan. So diabetes mellitus in children, and it's also known as type 1 or juvenile diabetes, or we can say that it is insulin-dependent diabetes mellitus. It is a chronic metabolic disorder characterized by hyperglycemia as a cardinal biochemical feature caused by deficiencies of insulin or its action, manifested by abnormal metabolism of carbohydrate, proteins, and fats. So it is one of the most common endocrine problem in children. That's a juvenile diabetes mellitus. So the type 1 or insulin-dependent diabetic mellitus, it's one of the autoimmune process and beta cell autoimmune destructions, absolute insulin deficiencies, and insulin for survival. Like type 2 diabetes, insulin is not required for survival. We give oral hypoglycemic and all other substitutes, but for the type 1, the only treatment is insulin, and accounts for over 90% of childhood diabetes mellitus, and peak age incidence is 5 to 7 years, slightly male predominance, and it's prone to ketoacidosis. So type 1 diabetes, this is the most common type in children. Genetic susceptibility to type 1 is controlled by allele of the major histocompatibility class 2 gene expressed on hemoleukocytes antigen DR3, DR4 associated, and so certain other antibodies is important, like associated with the antibodies to glutamate acid decarboxylase and GAD. It is also associates with other autoimmune disease such as thyroiditis, celiac disease, multiple sclerosis, Addison disease, and etc. So when patient having celiac disease, multiple sclerosis, Addison disease, thyroid issues, the patient should be screened for the diabetes as well. And with hemochromatosis or patient having certain other disease, we should think about, because it is associated with autoimmune disease as well. So type 1 is associated with these autoimmune disorders. So type 2 diabetes mellitus, non-insulin diabetes mellitus dependent. Okay, so insulin resistance, basically insulin is present inside the body, but the resistance increase. So insulin resistance with relative deficiencies or secretory defect with or without a resistance does not require insulin for survival. A strong genetic component not prone to ketosis. Acanthosis nigrans may be present. No islet cell antibodies. And islet cell antibodies present in type 1 and associate with overweight teenagers. So this is mostly occurs due to the resistance to the insulin, and it occurs in the adult age. It is not common in children. And if we deal with the children, that's the type 1 diabetes mellitus or juvenile diabetes mellitus or insulin dependent diabetes mellitus. In other types, there's known as maturity onset diabetes of youth. That is a MODY. Early onset of dominantly inherited by type 2 and non-obese children, no islet cells antibodies, family histories in several generations, identified genetic mutations, that mutation of glucokinase, hepatic nuclear factors 1 and 2 gene, non-ketotic, and 2 or at least one family member diagnosed before the age of 25 years. So the family history is important in case of the diabetes. In other types, and usually known as neonatal diabetes, the hyperglycemia requires insulin in the first 3 months of life. Very rare condition, 1 in 4 lakhs, and it is associated with the intrauterine growth retardation. 50% of cases are transient, associated with paternal isodomy and other imprinting defect of chromosome number 6. And transient neonatal diabetes, permanent diabetes may appear later in life. So if baby having neonatal diabetes, there may be chance to develop diabetes later on in adult age. Secondary diabetes mellitus may be associated with a disease like a cystic fibrosis, in which the respiratory and GI symptoms occurs, recurrent chest infection, recurrent history of diarrhea, altered bowel habits, and patient suffer from diabetes. Hemochromatosis and drugs like we can say immunosuppressive therapy or drugs like, which is used for certain other diseases like aspergillus, and it causes the diabetes. So the secondary diabetes mellitus associated with cystic fibrosis, hemochromatosis, and drug like aspergillus. So how we will diagnose, and what are the basic principles, or what are the clinical features? First, in type 2 diabetes, mostly the patient presents with a polyuria, polydipsia, weight loss, and all these things. But in type 1 juvenile diabetes mellitus, even we first time diagnose this case, when patient came with a diabetes ketoacidosis, or a patient may become sick having acidotic or cosmal breathe, and we'll check the blood sugars and it is too high, we worry that this patient may have. And if check the urine for the ketones, and if we will do the ABGs, it shows the metabolic acidosis. Patient may have severe dehydration, and it is one of the medical emergency. So it is an alarming sign, and if one family members are having this problem, we should be conscious, and we should screen for other SIBs because there may be chance. And if a patient is having identical twins, there is 50% chance to develop diabetes. What are the sugar level, and how we will consider when we will consider that this patient may have diabetes? So symptom of diabetic mellitus usually occurs and cause the plasma glucose concentration more than 11.1 millimoles. It means that more than 200 milligram per deciliter and more than 10 millimole for the venous sampling. And fasting plasma glucose levels more than 7 millimoles, that's more than 126 milligram per deciliter, and 6.3 consider for the venous sample or capillaries. 2 hours postprandial or post-load of glucose is more than 11.1 millimoles per liter during the oral glucose tolerance test. Oral or GTT test, and mostly we are not performed in the pediatric age because there may be the chance of hypoglycemia and all these things. So, but at least we should know the OGTT or glycemic tolerance test, and after 2 hours of the load of glucose, it's more than 11.1 millimole. So the fasting level is more than 126 milligram per deciliter, and random is more than 200 milligram per deciliter. Yeah, usually you can say the plasma level is more than 200 milligram per deciliter. It's a symptomatic for the diabetes. And certain levels, but we must keep in mind about the hypoglycemia as well when we treat the when we treat the diabetes. If we give the insulin or certain drugs and it causes the hypoglycemia, so if blood glucose levels less than 40 milligram per deciliter is the severe hypoglycemia, and blood glucose level in between the 40 to 70 milligram per deciliter, it is a mild. But when newborns or neonates come to an ICU, that mother giving history, my baby is lethargic, not taking feed, and since the last 6 hours, 7 hours, you are worried that what happens to the baby, and if you are checking the blood sugar, it is less than 50 milligram per deciliter, you can label as this is a patient, baby having hypoglycemia. And you must correct the electrolytes imbalance and hypoglycemia in neonates. Otherwise, persistent hypoglycemia have negative effect on the brain development, all these things, because the calories requirement for babies and even adults, you should have a euglycemic or normal glucose level. Preclinical diabetes mellitus occurs months to years preceding the clinical presentation of type 1 diabetes. And type 1 diabetic mellitus, you have antibodies. So antibodies can be detected as a marker of beta cell autoimmunity, that is GAD, glutamic acid decarboxylase antibodies. This is present up to 80% in type 1 juvenile diabetic mellitus. Okay? Insulin antibodies, important antibodies up to 100% you detect in type 1. Islet cell antibodies and IA antibodies from the 80 to 90% of the patients you got these antibodies. So this is important clues that you have found the antibodies that for the beta cell autoimmunity, that is a glutamic acid decarboxylase, insulin antibodies, islet cell antibodies is important, and insulin antibodies up to 100% and GID up to 80%. Clinical presentations, as I told you earlier, vary from non-emergency presentation, that's polydipsia, polyuria, weight loss, anuresis, to severe dehydration, shock, and diabetic ketoacidosis. Diabetic ketoacidosis is one of the medical emergency, and if patient is normal, parents usually in the denial phase, my baby is okay, having no diabetes, all these things, but when you check the baby's blood glucose, sugar levels high, and patient having metabolic acidosis, patient have cosmal breathing, and the patient in severe dehydration, patient may have altered state of sensorium, patient might have any fats or CRs, and in urine you check for the ketosis. So onset may be varies. Onset may be acute, precipitated by an acute illness, or more chronic or insidious over weeks or even months. So mostly the incidence onset may be triggered or may be precipitated by any acute viral fever or any infectious disease. So how you will investigate? You should do the blood glucose levels, and that's higher even in fasting or normal, and the blood glucose level of you can do the postprandial blood glucose level and check the urea and electrolytes. Okay, and in electrolytes, if patient has severe dehydration, you may have a hyponatremia, hypokalemia, and ketones in the urine, and islet cell antibodies, that is a glutamic acid decarboxylase, insulin antibodies, islet cell antibodies. This you can detect. And if you will check the CBC, the hematocrit level is increased due to the dehydration. Even hemoglobin level might be falsely increased due to the hemo concentrations. And if you will check the hemoglobin A1C, it is increased, and it is a important predictor. It will reflect the glucose level or hypoglycemia, diabetes since last 3 months as well. And if you will check for the lipid profile, because the high level or deranged lipid profiles in the case of the diabetes. So check the HbA1c for the good glycemic control or compliance of the patient. You will check by the checking A1c. And check the urine, check CBC, electrolytes, glucose levels. Because if you keep a good glycemic control, there's the least chance to develop complications. And you know that complication of diabetes are very worse if a patient having poor glycemic control. Even if a type 1 juvenile diabetes patient having hyperglycemia, DK, mostly their daily activity life is also affected, and patient baby is unable to perform his school activity and all these things. So we have to encourage, we reduce the anxiety, we educate the patient regarding their condition. These are the very important. And if I once have seen the patient and the family suffering from this condition, you counsel them regarding their dietary, nutrition, insulin levels, and insulin therapy. So dietary counseling and nutrition both are very important in the pediatric age group. Even if we are medical students and all this, one of our colleague might suffer from this, and that baby from the then that remained on the insulin therapy. So check for the complication as well. Okay, modalities. Sub, Modalities of management required multidisciplinary team, and insulin therapies, diabetes education, exercise, diet, psychological care, and monitoring of the blood glucose levels. And child's growth is an important for uh, regarding the nutrition, and the parents' educations regarding the diabetes. And as I have already told you about the World Diabetes Day, because on that day, usually we perform the awareness. We give the message to the public awareness regarding this diabetes, because the burden of the diabetes is increasing day by day. So our goal of the treatment is it is one of the multidisciplinary team, and patient must know about the insulin therapies, diabetic education, the exercise, diet, psychological care, because it is a lifelong process. So motivational therapy is an important, and monitoring of the blood sugars and any complication. So the insulin concept, the basal and bolus. Basal insulin usually supplies the glucose production between meals and overnights, 40 to 70% of daily need. And bolus insulin means meal time. It limits bolus insulin meal time limits hyperglycemia after meals, immediate rise and sharp peak at 1 hour 50 to to 60% total daily insulin requirement for meals. So the basal insulin suppresses glucose production between the meal and overnight. Okay, and requires the 40 to 50% of daily need, and bolus insulin mealtime limit hyperglycemia after meals. Means immediate rise and sharp peak after 1 year. 50 to 60% daily insulin requirement for the meal. Complication comprised of three major categories. One are the acute complications and long-term complications and complication associated by autoimmune disease. So if you categorize the complications, you look for the acute complications, long-term complication, and complication caused by associated autoimmune disease. An acute complication reflects the difficulties of maintaining a balance between insulin therapy, dietary intake, and exercise. Long-term complications, you have to check for the complication like foot care, eye care. You check for other system like kidneys and all these things, and other autoimmune disease like celiac disease and patient having thyroid problems. You check for these conditions as well. And acute complications, patient may have hypoglycemia, diabetic ketoacidosis, and infection. So three are the more important, like hypoglycemia, diabetic ketoacidosis, and infections. You prompt treat this condition to avoid any dangerous condition like patient may die if you will not treat appropriately. So hypoglycemia defined as blood glucose levels less than 60 milligram per deciliter or 3.3 millimole per liter for preschool children, and values below 70 milligram per deciliter, 3.9 millimole per liter should be caused for the concern. Severe episodes occur in 10 to 25% of the patient per year. Commonest acute complication of type 1 diabetes mellitus. Why worry about hypoglycemia? Because recurrent hypoglycemia can lead to hypoglycemia unawareness. 25% of diabetes mellitus can lead to epilepsy, learning difficulties, and death accounts for 4% of death in diabetes as a result of an unintentional trauma. So good glycemic control for the brain. And if persistent or recurrent hypoglycemia, the patient having poor cognitions, learning difficulties, patient may have seizures, and if hypoglycemia worsening, it can cause death up to 4% in diabetic complications. Diabetic ketoacidosis, very important, and it is one of the life-threatening medical emergencies, and the most important cause of mortality and severe morbidity in children with diabetes, particularly at the time of first diagnosis. And early recognition and careful management are essential if death and disabilities are to be avoided. So the early recognition and careful management are essential if death and disabilities are to be avoided. Diagnose. How we will diagnose DKA? As I've told you earlier, that hyperglycemia, if a glucose level more than 200 milligram per deciliter, ketonuria more than 5 millimole per liter, ketonemia, and metabolic acidosis. It means that the venous pH is less than 7.3, metabolic acidosis less than 15 millimole per liter. So the metabolic acidosis with ketonuria, hyperglycemia, and along with patient may have clinical features like severe dehydration, patient baby may be in the shock, patient have recurrent or frequent profound vomiting, polyuria despite dehydration, weight loss in spite of good intake, acetone breath. Acetone breath is important. That's osmolar respiration, deep and rapid respiration. Patient is unconscious or in coma, in shock, you must smell the breath. You have a acetone breath. You may have The smell of this acid on breath, it will give the clue that patient may have decay, altered sensorium, or a sign of raised intracranial pressure, and patient having bradycardia. So these are the diagnostic criteria for the diabetic ketoacidosis. Risk factors as initial presentation: young age less than 5 years, low socioeconomic backgrounds, and established type 1, higher A1C level, adolescents, particularly female, and those who are having poor compliance and already diagnosed diabetic, but they're not using the insulin, and mostly they escape their doses and they may suffer from this decay. Psychiatric disorder, longer duration of the diabetes. So severity of decay further depends on the pH level. A mild pH level less than 7.3, and but more than 7.20, and moderate the pH is less than 7.20 and above the 7.10. In severe, the severe metabolic acidosis pH less than 7.10, and along with the bicarb, and in severe metabolic acidosis the bicarb level is already low. So in mild, you may found the bicarb levels more than uh, less than 15 but more than 10, and in moderate bicarb level less than 10 but more than 5, and if severe metabolic acidosis you have a bicarb level less than 5 millimole per liter. So pH and bicarb, you check in ABGs, and you will label, you will classify the severity, and you have a prompt treatment. You have acutely management of this patient. Your aim is to control blood glucose level. Your aim is to control, to correct the electrolyte, to correct the dehydration and any associate complication, and patient may have any infection. You give antibiotics, and closely monitoring of the blood sugar level and all these things, and you can change or switch the um, fluid level according to the blood sugar level. So goal of therapy is correct the dehydration, correct the acidosis, reverse the ketosis, restore blood sugar level to near normal, and avoid complication of the therapy, identify and treat any precipitating events. So these are the goal of therapy: to treat the diabetic ketoacidosis, hydrate the patient, correct the acidosis, control or restore normal blood sugar by insulin therapy, avoid complications of the disease associated or the treatment associated, identify and treat any precipitating events like an infection, you treat accordingly. So the emergency assessment is important: brief history to find the cause, weight the child, assess the degree of dehydration, assess level of consciousness by using the GCS scale, Glasgow Coma scale, and biochemical assessment is important. Check the urea, electrolytes, sodium, potassium level, bicarb level, and check for the urine for the ketones. So these are the important parameters: blood sugar level. And supportive therapies, as secure airway, a peripheral IV catheter should be placed in for convenient and repetitive sampling, cardiac monitoring, give oxygen to patient with severe circulatory impairment or shock, give antibiotic to febrile patients after culture have been taken. Fluid therapy is an important art to manage decay. Okay, in first hour, you give the bolus, that's a 20 ml per kg normal saline with insulin infusion at the rate of 0.05 to 0.1 unit per kg per hour. So mostly we give the 0.1 unit per kg per hour. And second hour and subsequent hours, you switch the fluid to 0.45% normal saline, and patient continuous insulin drip plus 20 MEq per liter potassium. So you give the potassium, but for the potassium, you should be conscious, check the urinary output. Patient have a good urine output or patient having urine. 5% dextrose if blood glucose level less than 250 milligram per deciliter, 14 millimole per liter. And 1 millimole is equal to 17 milligram or 17 to 18 milligram per deciliter. So add 5% dextrose if blood glucose level is less than 250 milligram per deciliter. And IV rate is 25 ml because we giving the 15 ml in a bolus and 85 ml per kg plus maintenance minus bolus divided by 23 hours because we are giving this fluid adjusting in 23 hours. Okay, so this is the formula calculation for the fluid. I maintain IV insulin until decay resolve and pH more than 7.3, bicarb more than 15 millimole per liter. Stable serum sodium is 135 to 145 millimole per liter, and patient having no emesis means no vomiting. Then switch to sub-Q insulin, maintain IV insulin 30 minutes after sub-Q. For when you switching the sub-Q, up to 30 minutes you should give an infusion insulin, and after that you stop the IV infusion and patient should be kept in the sub-Q. And ketone may take longer to clear. So ketone is not a parameter for the treatment purpose, but it is important parameter for diagnosis purpose. Ketone may remain for longer time even after you have a good glycemic controls and all these things, but in decay you may found the ketones. So complication of therapy, if you are not good in calculations, there may be inadequate rehydration. Patient may have hypoglycemia, patient may have hypokalemia, patient have hypophosphatemia, and patient may have cerebral edema. So thank you. This is all about insulin therapy, and this is all about this diabetes mellitus type 1, type 2, MODY, and all these forms. And the patient suffering from the diabetes, you should give the counsel the parents and important counseling regarding the insulin, and watch and observe for any complications. And your aim is to improve the life of the child, and for the good glycemic control their IQ level become better, and his or her school performance will become better. And give good counseling and encourage the parents and be aware about this, because mostly that it is one of the autoimmune type disorders, and nutrition diet having a major role in type 2 diabetes. It is not related with the type 1 and obesities and over diet and all these things happening in the type 2 diabetes. So if one saves or one family member suffering, there may be a chance that others may suffer from this problem. Okay, so thank you very much for your listening the lecture and for your kind attention. Thanks a lot. If you have any query, question, you may ask. Okay. I have a lecture. If you have, you need this lecture, I will send you, I will email you this lecture to you. Thank you. Any other questions? Thank you very much. Thanks a lot.